Greetings from Denmark, Europe. My name is Henrik Selk. I'm a licensed psychotherapist here in Denmark with several years experience in theoretical and practical risk prediction, prevention, assessment, diagnosis and treatment of moderate and severe mental disorders. Currently, I'm now a grateful student in the doctoral program in psychology at this great university, Carl Sagan. Currently, I'm participating in my 5th course, Advanced Psychopathology, conducted by the amazing Dr. Rebecca Wilson. My topic today, borderline personality disorder, is one of the most common and disabling mental disorders among my younger patients. BPD is for me a fascinating topic from a scientific point of view because of the complexity and the comorbidity with other mental disorders like eating disorder. In my clinical work with the other mental health staffs, the patients and the peers, genetic, epigenetic and biological indications along with cultural influences will also be considered in my presentation, and the diagnosis of the BPD. BPD is diagnosed predominantly about 75% in females, which correlates with many of my patients and their clinical presentations. In the connections with the above differential diagnosis, BPD is a psychiatric disorder associated with significant morbidity and mortality. However, the neurobiological alterations underlying the condition remain poorly understood. As a result, we as clinicians often experience the existing treatments remain inadequate. But let me take you a small tour to the history of borderline personality disorder. Where did BPD come from? Well, in the 19th century, borderline was described as a condition that was fuzzy between two different psychiatric problems, bordered on or overlapped with schizophrenia and non-schizophrenic psychosis. In my terms, it was a wastebasket diagnosis. The category 1 neurosis patients is aware of reality but had emotional problems, for example, depressions and anxiety. Category 2, the psychosis, patients who had unusual thoughts, experienced hallucinations not based on reality. These patients were diagnosed with disorders like schizophrenia. Psychiatrists use the term borderline for patients who had a hard time seeing both the good and the bad qualities in people, and that led to unstable and chaotic lives. But the problems was not serious enough to be labeled psychotic, but too troubled to be neurotic. Borderline personality disorder, well, typical, it's a person that often experiences a repetitive pattern of disorganization and instability in poor self-image, mood, behavior and personal relationships. That can cause distress with friends and at work. The symptoms are typical: fear of being abandoned, may have trouble with anger, have outbursts or scared of anger that they avoided. They have difficulty trusting others. They could be manipulative. They have frequent shifts of lonely depression to irritability and anxiety. They are often seen as unpredictable and impulsive behavior, such as excessive spending, gambling, promiscuity, shoplifting, overeating, and self-damaging actions. A mental health professional like me experiencing diagnosing and treating mental disorders. Well, other could be a psychiatrist, psychologist, clinical social workers, and a psychiatric nurse, as we experience here in Denmark. All in all, we have to make a thorough medical exam that can help to rule out other possible causes of symptoms. The etiology, what causes BPD? Well, we clinicians are unsure of the exact and precise causes. We are not fully understanding the genetics, biological, environmental, and brain abnormalities. But what we know is the genetics is BPD is often inherited among family members. Biologically, 60% of the research suggests the risk of developing BPD conveyed through genetic abnormalities. These abnormalities appear to affect the functioning of the brain pathways that control the behavioral functions and emotion, information, processing, impulse, and cognitive activities. About the environmental side of BPD, well, we know for a fact that poor parenting, early separation from parents, emotion, physical, sexual abuse, incest is in the center of the factors that can cause a BPD. If you look at the DSM-5 criteria, well, in relation to BPD, we see a perceived pattern of instability of interpersonal relationships, a damaged self-image, and a marked impulsivity beginning by early age adulthood. This is present by in a variety of contexts as indicated by 5 or more from the below. The frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating extremes, ideation and devaluation. Identity disturbance, impulsivity, as I mentioned before, recurrent suicidal behavior, gestures, threats, or self-mutilating behavior. And, of course, the affective mood instability, as we often see in patients with BPD. Another thing I typically observe with my patients in BPD is the chronic feelings of emptiness, the inappropriate, intense anger or difficulty controlling the anger. They have all of them, almost all of them, transient stress-related paranoid ideation of severe dissociative symptoms. This is typical from my patients. Let me note that BPD rarely stands alone. Typical, it co-occurs with other disorders, as I mentioned before, eating disorders, but it could be bipolar depression or substance abuse. BPD affects, we know, about 2 to 6% of the population, depending where you live in the world. The estimate is 10% of the outpatients and 20% of the inpatients who present have BPD. As I mentioned before, more females than men are diagnosed with BPD. It's 3 to 1 in that category. Women's co-occurring disorder are usually linked with major depression, anxiety, or the eating disorder, as I mentioned before. Men are linked with substance abuse and antisocial personality disorder. 55% of our patients self-injure. Approximately, and that is serious, approximately 10% of individuals with BPD complete suicide. Up to 80% also of my patients with BPD having suicidal behaviors. BPD affects 6 to 10 million of Americans, or about the size of the city of New York. Twice that of bipolar and schizophrenia. 35% of youth who commit suicide have features or traits of BPD. This number is 400 times higher than the general population, and younger women with BPD have suicide rates of 800 times higher than the general populations. Common, dangerous and fear-inducing feature of BPD are the self-harming behaviors, the cutting, the burning, the hitting, the headbanging, the hair pulling. Physical harm generates a sense of relief to alleviate emotional pain. This occurs by stimulating the production of endorphins. The release of the endogenous opiates produce the brain provide a reward to the self-inflicting behavior. Let me talk about the treatment. The psychotherapy and the medication management. Well, let's start with medication. Most effective when used in conjunction with psychotherapy. It reduces the symptoms of BPD, but not treat the BPD itself. In my clinic, here in Denmark, in Europe, medications serve to improve chemical process required for optimal brain functions, is antipsychotic and mood stabilizers. They are most useful. Among the antidepressants, I could mention Prozac or Zoloft. Among the mood stabilizers, I can mention the Lethobid. If I may talk about the psychotherapy, I have in my clinic good experience with dialectical behavior therapy, DBT, cognitive behavioral therapy, CBT, mentalization-based therapy, and systems training and emotional predictability and public storming. Let me pause a little bit about it. What is DBT? Well, it's a modification of CBT for the treatment of chronically suicidal and self-injurious individuals with BPD. DBT differs from traditional CBT in its emphasis of validation. As a therapist and my patient, we work on to accepting uncomfortable feelings, thoughts, behaviors versus struggling with them. Once an identified thought, emotion, behavior is validated, the process of change no longer appears impossible for my patient, and the goals of gradual transformation becomes a reality. As a psychotherapist, my aim is, and my patient's aim is, to focus on developing coping skills. The CBT, as I mentioned before, it's another form of treatment, a well-documented treatment that focuses on examining the relationship between thoughts, feelings and behaviors. We, my patient and I, explore patterns of thinking that lead to self-destructive actions and the beliefs that direct these thoughts. People can modify their patterns of thinking to improve their coping. I always involve homework. It can be stressful for the patient in the start, but over time it is success. Why I have picked out this bipolar disorder as my topic today. Many people ask me, why is BPD a problem? Well, BPD is one of the top reported disorders, for example, among prison inmates. Prison inmates are diagnosed with the linking of the disorder with criminal behavior. 25 to 50% of inmates, also here in Denmark, in prison suffer from BPD, mostly in the women. Prison-based mental health care, also in Denmark, is problematic. That is because of the lack of resources, the difficulty in making referrals, the scarcity of good mental health providers, and the inappropriateness of prison as a setting of care. It is not uncommon with forensic mental health service for regional secure units to actively exclude patients with a primary diagnosis of personality disorder because they do not consider this to be the core business. In many parts of Denmark, there's no specific services, and when services are offered, they tend to be very individualistic. So, in general, people with BPD have difficulty controlling their emotions and distorted perceptions of themselves and others. The result is impairment in functioning at home, at work, and relationships. These impairments are all too often can lead to a life of incarceration. Thank you very much for listening. This topic, borderline personality disorder, is very crucial for us clinicians to continue the research, to continue developing theoretical and practical methods to risk prediction, prevention, diagnose and treatment for borderline personality disorder. Thank you once again.